Hi, welcome to Detours, Understanding Acquired Brain Injury. And today I want to talk to you about something which affects all of us, and especially those of us who've experienced acquired brain injury. I want to talk about headaches. Today will be a survey, so a quick look through the primary types of headaches that those of us who've had acquired brain injury would experience. And I want to just look at symptoms and a quick review of some of the basic treatments. This is not meant to substitute for a physician's care. So if you're experiencing headaches, you should contact either your primary care doctor or you should consider going to urgent care or the emergency department. But the goal of this will be just to address the different types, etiologies, that is, cause, and things that you can do. All right, first of all, those people who suffer traumatic brain injury, especially those who have mild traumatic brain injury, about 95% of all of those who have them will suffer what's called a post-traumatic headache. And about around 20 to 25% of those who have moderate to severe traumatic brain injury have a headache. Part of the reason why it's such strange numbers is because most people have moderate or severe have usually or remain unconscious or have altered memories, and so they don't remember most likely the headache because it usually resolves within a relatively short time, specifically the post-traumatic headache. But then after that, sufferers of all degrees of traumatic brain injury, whether it's mild, moderate, or severe, do experience headaches after. But the initial headache from the blow to the head or from infection or whatever it may be, that usually is resolved. Although mainly we're talking about a traumatic event, physically traumatic event, so a motor vehicle accident or that kind of thing, or assault or whatever it may be that caused the initial trauma. Typically, onset is within about 7 to 14 days, and they resolve within 6 months. 40 to 50% of all traumatic brain injury patients are complaining of a headache from the initial year that they've experienced it. So, and then from there, they will experience just chronic regular headaches. And there are different categories of headaches that we'll be quickly looking at and talking about in this survey. So the different types of headaches. We do need to look at and to know, first of all, there are two overall classifications by the International Headache Society. First one are those kind of headaches that are what are called primary. Primary headache is idiopathic. That means we don't know the cause. It's just a headache that comes on, and it's due to chemical neurotransmitters and due to stressors and things like that may cause it, but we can't point to something and say that's what caused the headache. Secondary headaches have identifiable causes, traumatic brain injury, or due to exposure to something that immediately we can say that's what caused it. Secondly, there's chronic or episodic. Episodic headaches last less than 15 days per month. You have headaches that are shorter than 15 days and last less than 3 months. So if you have a headache for like 3, 5, or 7 days over that month, and it's 1 month, and maybe you may go a couple other months, you may go 5, 6, 7, 8 months and not have them and have another one for a couple days, those are considered episodic. Chronic headaches obviously last 15 days or longer, and so you may go for several weeks, obviously, and you also have these headaches of 15 days or longer for more than 3 months, and those are defined as chronic headaches. And a lot of traumatic brain injury sufferers have chronic headaches, and so how that works kind of makes it more complicated because it involves more pain triggers and it becomes more complicated. All right. The most common type of headache, as you might expect, we find is the migraine following traumatic brain injury. They also, you may find that migraine is a separate disorder. Migraines, you may have had them before you suffered your traumatic brain injury, but And so they would have a separate diagnosis, but many people never had them before and now have migraines as a result of their traumatic brain injury. So let's talk about one of the types of headaches that may be a result of your traumatic brain injury. First, I want to talk about tension type headaches. Most people like to dismiss the tension headache and say, well, it's just due to stress or whatever. But tension headaches are very painful. They involve tension in the muscles in the neck and throughout the head, and they also involve a complex neurochemical cascade inside your brain as well, and it activates other receptors both in the spine and in the meninges in your brain. So tension headaches are more than just tight muscles, and it's important to remember that. And they can become chronic and cause as much pain, if not more in some cases, than a migraine. So tension headaches, they deserve the attention and respect and require a physician's care if they become chronic. And that's really the key for all headaches. Are they episodic or are they chronic? So a tension headache is primary, so it's idiopathic. We don't necessarily know what brings it on, but we do know that they are a primary type of headache. Secondly, they are generally the second most common form of headache in traumatic brain injury. They do follow some similar pathways to craniocervical headaches, which we'll talk about later. And they sometimes are hard to differentiate between the craniocervical headaches versus what's tension headaches. So diagnosis can be tricky. They can, obviously, when they're episodic, if they're short term, most doctors will advise you to treat with NSAIDs, just over the counter acetaminophen or Tylenol or stuff like that. You usually can control them with that. You also could use like TheraBands or things like that to put a little bit of extra tension, things like that. If it's episodic, you can handle these at home, which is sometimes why they were treated or viewed as less serious, but the pain levels can be very high on these things. So it's important, if it lasts for longer and if you can't manage it at home, to contact your physician. And there are headache specialists. There are neurologists who are specialists in headaches, and there are nurse practitioners also who specialize in headaches or headache clinics. So it's important to follow with this. So chronic tension headaches need professional management. Okay. They often present, and what you're looking for is they present bilaterally. So if you have a headache that's on both sides, that feels like crushing in a vice, that is most likely a tension headache. Also, they don't get worse with physical activity. That's one of the markers of a tension headache. They stay pretty much as awful as they are. They also don't present with new or sudden sensitivities to light, sound, taste, smell, beyond what's typical for traumatic brain injury. I mean, if you have trouble with light and sound and stuff, that's normal for you. That you don't suddenly have now extra problems with light and sound and things like that. So it's just a very tough, strong bilateral headache. But you don't suddenly have photophobia, as in sensitivity to light, autophobia, the phonophobia, sound sensitivity, and like problems with smells and stuff. Whereas this would be an immediate onset or an onset in a prodrome with your migraine. So that's the key difference there, is like you don't have extra symptoms that come on. You don't have problems with exercise, movement, things like that. And that's one of the key distinguishing features. All right. So about 38% of the episodic tension headaches will keep presenting themselves for up to a year or later after the initial head injury. So if you have a traumatic tension type headache, you will be getting these more regularly. And 2% will become chronic, will have a chronic tension type headache after your traumatic brain injury. There is a greater prevalence among women than men, according to the research, but not as great of a difference as seen in migraine. So you'll see a bit more of an even balance for post-traumatic tension type headaches, amongst between women and men presenting. So post-traumatically, you'll see a higher even or more even balance between men and women. Um, Also, traumatic tension headaches and neck and head injuries. Um, it's related also to extensive strain in the neck. And so, what you'll see is a lot of inflammation of the tissues, and that will release substance P, which is a pain signaler, and also bradykinin and histamines, serotonin, prostaglandins, and repeated signaling by these inflammatory factors and these pain signaling factors will activate the pain fibers, and which will in turn then release calcitonin, reactive proteins, and substance P, and that will trigger a deeper pain response, especially if it keeps happening over and over and over. Other nerves become sensitized, and so you have kind of a cascading response over time because repeat exposure again and again and again, it will activate chronic pain pathways leading to a chronic headache and a chronic tension type headache. It recruits the higher level neurons, and that will trigger pain receptors that are normally dormant in the brain. And so this is partly why chronic tension headaches become a problem. And it's a similar mechanism in migraines too, and why there's a lot of similarities between these two kind of headaches, because you get this central pain activation in both of them. And then the pain receptors that fire more often, they will activate, they trigger in the head and the neck and the upper back. And these signals converge on the trigeminal caudate nucleus in the brain, and it activates these pain receptors that are normally dormant, and it drops your pain threshold. So you're even more sensitive to things that would cause pain and sensation. And sometimes things that shouldn't cause pain or wouldn't cause pain normally cause it. It's called allodynia. And so, like, even just touch or loud noise, screaming kids, whatever, triggers the pain response that it normally would not set off. And this is where you see that kind of blending for migraines, a central pain response. And so you also have like more tenderness and sensitivity in your face. And so these responses require treatment by a physician in order to take care of it. Things that work or used, each person's different, so same treatments don't always work. Physical therapy is often used. Anticonvulsants, antidepressant medications are sometimes used to mitigate the pain response by changing which neurotransmitters fit into which receptors. And those, as we talked about, the higher order neurons, the goal is to settle them down so they're not quite as excitable. Antidepressants, again, the goal is to silence some of those extra neurons which get recruited. Pain medications, therapy bands, resistive exercise machines. Research has shown that that's effective. Botox in the head and neck in order to block those nerves to prevent that recruitment. Other research is still ongoing, but those are some of the different treatments that are used. Also, it's Plano-fascial NSAIDs for some people are effective to take the inflammatory factors out, because a lot of them play a role in signaling the substance P. And there's the CGRP substance P blocker. Those are new coming online right now. And you want to talk to a headache specialist to get some help. Cervicogenic headaches, which are headaches from injury to the cervical spine, base of the neck, shoulders. When there's damage there or to the trigeminal nerves, you also get headaches from that as well. And depending on where you're injured and which nerve roots will determine what kind of headache and where you get your pain. And if the damage is serious enough, it may cause crossing signals, things like that, because they lie very close to each other, the nerve roots. And so you may get some missignaling as well. And it makes it harder to treat also. And you see this in spinal injuries and things like that. The signals are sent along those nerves to the trigeminal caudate nucleus. Again, same location, which makes sense that would be a target for treatment too. If it's in the C1, C2, the atlas and the axis, right up here at the top, at the base of your skull, you'll get signaling that cascades to the trigeminal nucleus, and then the headache tends to be here in the orbits around the eyes and right to the forehead. If it's the C2, C3, again, the axis and C2, C3, your cervical vertebrae, you'll get pain here and back to the parietal region. And if it's C3, C4, it'll go to your chest, your shoulders, and your neck. And if damaged to all three, you could have it your shoulders, half the side of your face, either side, both eyes and forehead. Tension and a very sharp kind of pain. Treatment is difficult because there's no medication that works on these kind of headaches. You have to either use laser thermal ablation, or you could try Botox and deaden the nerves. But again, they do regenerate. Same thing with ablation too. So eventually there's regrowth, but at least it gives you some relief. And neurosurgery on the neck, very difficult. So finally, we've got migraines, and these being the most common. By the Headache Society, they talk about multiple different types of migraines, and we know about the primary types, of which no known cause, and the secondary, for which we know the cause. A migraine generally tends to be primary, for which we don't actually know the cause, but with head injuries, we look at them as secondary. But there's migraines without aura and migraines with aura. There's your typical auras. Maybe your vision may be swimmy or maybe cut. You may have a visual field cut. You may have grayed out vision. You may be dizzy, nauseous. Along with it, you may have hearing loss. You may hear things. You may smell something unusual, like something burning. These are all kinds of auras, and there are many others. You may lose speech. You may lose function in your hand. We're described more often as a classical aura. Prolonged aura, if for your migraine you have an aura that lasts for a much longer period of time. Hemiplegic aura, where your body's half paralyzed. It looks like a stroke, a cerebrovascular accident. And so it's important to make sure you speak with your neurologist about these kind of things. Migraines without aura. Obviously just immediate onset, or immediate onset with aura. So you get your aura and immediately have the headache. Ophthalmoplegic aura, or ophthalmoplegic migraine, where it attacks your vision, where it may alter your vision and you may not even get pain, or where you see double. Retinal migraines, that is where it affects how you see, or it alters. You may have visual illusions and distortions because the blood vessels are attacked around inside the eyes, and you get some leakage and inflammation. And then finally, there are complications. You can have status migrainous, where it just goes, or you may have an infarction. Lack of oxygen due to the inflammatory response of blood vessels, and it may lead to a stroke. So it's really important to know what you're dealing with. So again, consulting with a physician who's a specialist in migraines always really is important. The stages of migraine prodrome, the early initial first symptoms. Your eyes may water, you may get dry in the mouth, you may hear something. Then your aura. Not everyone has an aura. The headache itself, which typically is one-sided, but it can switch sides depending on the nature of your migraine. Sometimes it could be both, but that's less common. Usually it's just one side, but alternating. Finally, the postdrome after the headache, which is symptoms that follow up, that extreme fatigue, or maybe hunger in some cases. It just is very important that you be aware of your headache. And so many people keep a headache journal to track their symptoms so they know what's going on. So, after you've recovered, write down what you remember, what you experienced, or have a family member, a loved one keep track of this. And if it's new to you, it's really important to know what's going on. And that first migraine, or that first tension headache, or that first craniocervical headache, get a doctor involved. Make sure you're being treated. And it's not something to let go in case it's something else more serious. Different, kinds of treatments are based on the classic kind of treatments for the tension headaches. NSAIDs, some people it's mild enough that anti-inflammatory medications work. Other people, we used to use the ergot-based medications, which were used before we had the serotonin-based abortives, before we had Maxalt, and before we had sumatriptan, Trexamet, all that good stuff. The triptans, basically, which cause the blood vessels to constrict again. But that's one of the standards. Another one is the AAC, the AC treatment, which is done in the initial stages, which is also still the gold standard. Aspirin, acetaminophen, caffeine. And that's often recommended. The combined pills are recommended. That's your migraine pill, that you get over the counter. It's often recommended first before you jump to the serotonin-based abortives, because they can affect your blood pressure. If you have a history, you can have a cardiac event. So it's important, again, to communicate with your doctor before you get one of these. Also, the CGRP, the calcitonin blockers, these are new. I do want to talk about them particularly later, but on another video. But these are new medications, injectable. They seem to be very effective in controlling and limiting these kind of headaches. Botox, which blocks the initiation of those neurons which cascade from one to the other. We all know, there are other meds you've heard of. These I've just spoken about earlier. The tricyclic antidepressants are used oftentimes. Topiramate, which is an anticonvulsant, also helps. Beta blockers, calcium channel blockers, they're used also for obvious reasons in reference to the CGRP injections we were talking about. And good old-fashioned dark, quiet room rest. Silence, not bothering mom or dad, not bothering kids, just cool washcloth, let them rest. Most migraines resolve within anywhere from 4 to 72 hours. If it's longer than that, you may be dealing with another kind of headache. You may have clusters. You may actually have cluster headaches, which are very similar in pain, structure, severity, but they repeat. And they go through cycles of repeating and then breaks and then repeating. Treatment is oxygen, most effective treatment. But there are other, Also, there are headaches from other causes. For example, elevated ICP, elevated intracranial pressure on the brain, can be very dangerous if not dealt with. Throbbing pain usually wakes you from sleep. It's painful in the morning. You'll notice it more if you're exerting yourself. If you're trying to move your bowels and you're blocked, you may notice a really bad, sharp headache. If you're lifting stuff, things like that may cause a spike in your ICP and a really bad headache. You get nausea, sometimes of vomiting with that, just like with the migraines. And it's better when you lay down or sit down. So this was a quick survey of types of headaches, symptoms, a little bit about causality, just a survey. And I just wanted to make sure to address that. And yet again, I want to stress, not a substitute for seeing your doctor or for diagnosing yourself. Just a quick reference. And so please, if you're having problems with headaches, see your physician, see if you can get to a headache specialist or a neurologist, PCP, urgent care, or emergency department if it's sudden, severe, changing condition. And if you want to see more content like this, please click like and subscribe. Hope you enjoyed this and found it useful and educational. Thank you. Have a good day.